necrosis factor blockers, which have become a very, very potent and important tool for a lot of diseases like ulcerative colitis, rheumatoid arthritis, psoriatic arthritis. You're hearing all these different things, and people are now becoming aware of TB. People are being warned, hey, look, before you start these, think TB, a message that we really need. But I got to be honest with you, none of these things really, really were that important until we had this case. And this case, I believe, really brings home what it really means to think TB. And I'd like to present the case first, and then we'd really like to have an open discussion about tumor necrosis factor blockers, including the basic immunology as well as the clinical implications. So if I may, I'd like to start with a case. So the case is, I want to start by showing you this. Hey, notice this. That Ivan's a handsome guy, huh? I like that they put a picture of me next to Ivan, so Ivan looks really good. But notice that we don't put a picture of Sundry anywhere there, because we can't let Sundry make either one of us look bad, So Sundry is way too good looking for us, so we couldn't put her on the slide. But, all right. Would you do me a favor, Donna? Could you put up my slides, please? Thank you very much. Sorry about that. All right. So the case is this was a 52-year-old African-American male. He had a history in the past of gout, non-insulin-dependent diabetes, ulcerative colitis, and he had migraine headaches. He was admitted to a hospital in Fort Lauderdale on April 28, 2010, and at that time he came in with a chief complaint of chest pain. They did a cardiac workup on him, and it was unrevealing, but while he was hospitalized, he was complaining of a lot of abdominal pain. And he gave a history of ulcerative colitis. It was diagnosed in Georgia 10 years prior, and previously he'd been maintained on salicylic acid derivatives. He denied any prior history of any prior steroid use. He had a colonoscopy performed while he was at the hospital, and it showed that he had severe colitis, which was not responding to the therapy that they were receiving, that he was getting in the hospital, with the mesalamine and the azathioprine, and it was recommended that he be started on infliximab, a Remicade IV infusion. So they placed the PPD just like they saw in the TV commercials prior to starting the infliximab, and the reaction was described by his GI physician as a 2-centimeter nodule without erythema or skin reaction at 72 hours, and the GI physician really wasn't sure if this was reactive or not. And notice on the commercials, they really don't go over, right, how to test, right, or what's a reaction. Now, they say think TB, get it tested. So he did. He went to his doctor, and at the time they did a chest x-ray at that time, and the chest x-ray showed an old granuloma in the left lung. He had a history of non-insulin-dependent diabetes for 20 years. He was born in the U.S., had no real international travel. He denied any history of previous TB exposure. He denied any stay in jail or prison, but he lived in a congregate setting for 1 year while he was homeless, and he also spent a great deal of time in prisons. He worked a lot of missionary work in the prisons and did a lot of work in the prison. He denied any history of a previous positive or reactive PPD in the past. So the GI physician wasn't really sure if this was truly a positive reaction, so he asked an ID consultant. And the ID consultant thought that maybe this reaction was a hematoma. And he still said it may have been a reactive PPD, and they recommended repeating the PPD, and subsequently the test was reported as quote-unquote negative, though there was no description of what the reaction was or how they came to that conclusion. They said negative. So at that time, they felt no LTBI treatment was felt to be indicated prior to starting the infliximab. And I guess my first question to you guys, if I can, is do you agree with this? Do you think that that maybe they've done anything else? So yes or no? So as you guys can see, and thank you for voting, guys, this is the fun part here, but it looks like, I don't want to say nothing, but this looks like the odds of my Giants beating San Francisco. I mean, I just want to make this clear, right, that this is the same thing. The vast majority, actually, that's what I really asked. Will the Giants beat San Francisco this weekend, And as you can see, wait, the vast majority is saying no. What is this about, No. But as you can see, I think most people on this phone call is saying that no, maybe they don't feel comfortable that this was not a positive. And let's go on. So if you feel that something else should have been done, what would you have done? Do you think any other additional evaluation was indicated? Do nothing, maybe get an IGRA, maybe do sputums for AFB, maybe do a CT of the chest, treat for the LTBI given the risk factors regardless of what the PPD or IGRA show, or IGRA, sputum, and CT, any of the above, or 2 and 4. This is kind of like what the, right now the Republican primaries are looking like right now. But I think what you'll see here, and thank you again for voting, guys, it makes it fun, but I think a lot of people are saying that they would work it up more. A lot of people are saying that they would get an IGRA or an IGRA with sputum and CT, and I guess a lot of you are concerned, which I do agree, that we don't have to just worry about is this LTBI, but what's the possibility, even before we start, that this may be active disease? And I think the answers are all relatively good. I think further workup probably would be indicated. So let's go on. So he was started on infliximab on May 4, 2010, and he was maintained on injections every 2 months, and his colitis got much better. And after discharge from the hospital, he claimed he experienced a fall, and it happened right in the end of May. And he said he had pain in his right shoulder since then. And he claims a month after this happened, an interesting thing happened to him. He had an episode of back pain, and he suddenly claimed could not move his arms or legs. He said it lasted about an hour, and it resolved on its own, and he didn't seek any kind of medical attention. And he just said he just was weird. He just couldn't move. And then approximately 6 months later, in January of 2011, the right shoulder pain was getting worse and worse. And they did an x-ray. There was nothing they could find. It was unrevealing. So they decided to get a second opinion, and he went to an orthopedic surgeon who recommended they do an MRI of his neck and shoulder for this pain. And what happened was that on March 18th, according to the hospital records, while he was being moved off the MRI table, he suddenly could not move his arms or legs. He became suddenly quadriplegic. Interestingly enough, at the time, he had no difficulty breathing was noted, but he could not move. And he was immediately transferred to a regional tertiary referral center. I was talking to the patient. He will tell you that those, and I can imagine this, the MRI staff were stunned. They didn't know what to do. I mean, he had suddenly, out of nowhere, as they were moving him, suddenly couldn't move. And what happened was he went to the other hospital with his MRI scans, and on the MRI they found that he had erosion of his posterior C4 and C5 vertebral bodies with an accompanying infiltration of the surrounding soft tissue consistent with an abscess. And I'm going to show you what you can see here actually on C4, C5. This is vertebral bodies. And you can literally see in the posterior section that they're all inflamed here, and there's an erosion. And you actually can see that this abscess is actually compressing the spinal cord right here. So he has a spinal cord compression. So this is this again, this is the axial view, and you can see how there's epidural enhancement that's around the spinal cord, and again, you can see this enhancement there. So there is a significant amount of disease in the spinal cord that's definitely impinging on the spinal cord. This is his chest x-ray. I know it's a little hard to see, but as you can see here that he has this small little granuloma in the left upper lobe, and otherwise was read as pretty much not, it was not otherwise not what he called. There was no other infiltrate. So he underwent an anterior cervical discectomy at C4, C5 with decompression of the spinal cord and debridement of the epidural abscess on March 19th. And the pathology was consistent with acute osteomyelitis, and they found that he had fibropurulent exudate and necrotic material. And just real quickly, I mean, I don't want to get too much into it because for the sake of time, but at this discectomy, all they essentially did is they removed the disc and the material that was pressing on the nerve root. Essentially what they just do is they go in the anterior part of the neck, and then they take out a piece of the bone, and then they remove the material to try to decompress any compression on the spine. This is actually a herniated disc, which is most commonly done for, but in this case they did it for an infection. So he was placed on flagyl and vancomycin and ceftriaxone, and he was placed on a steroid taper. And postoperatively, he required mechanical ventilation. He was having trouble breathing, and he was on the mechanical ventilator, as you'll see, for about 2 months, and was complicated by frequent lung collapses, mucus plugging, and he had to have a lot of bronchoscopies. He remained quadriplegic and then started having fevers. And again, remember, I want to start by telling you, despite being on the, as you already know, but we'll go on, despite being on the tumor necrosis factor blockers, nobody at this point thought of TB. They were treating him purely as a bacterial infection, and he was not getting better. So they repeated the CAT scan and showed that he had an increase in the abscess. And my question, I guess, is what would you do now? Would you continue therapy? Would you go back for training in order to become a neurosurgeon? With a lot of my staff always ask me to just leave, and they don't care if I went back for neurosurgical, but just get out of here. Or re-explore the abscess, sending the specimen for. You guys are all neurosurgeons already. You don't even have to go back to training, you know? I think most of us would agree that we would go back and re-explore this and do further studies. I want to say one thing about this case. Remember, this person's in a prominent tertiary hospital. I mean, so this is not happening in some community hospital. And I guess what my message is, and it's going to keep repeating, is think TB. And that's one of the biggest problems we're going to have in these cases with these tumor necrosis factor blockers. The majority of the community are not thinking TB, even though with all those fancy ads and all those beautiful warnings. But the patient had another anterior cervical discectomy and decompression on March 30th, and again, only bacterial studies were sent. He was not responding to therapy. He continued to have fevers, and he was continued to be quadriplegic. And on April 11th, he had another procedure. Again, they went in and they did the C3, C5 laminectomy, but this time they sent the specimens for AFB, and they were PCR positive for TB. He was placed on 4 drugs after he was found to be show no mutations on a molecular drug susceptibility. As you can see, while he was intubated, now he starts to develop bilateral infiltrates, and you guys already know the answer. And you can see when compared to when he only had the granuloma when he first came in, now he has bilateral infiltrates. And as you know, they went in and they bronchoscoped him, given that he had AFB in the abscess, and sure enough, he had TB again. So he had been sitting on a ventilator again with probably positive smears. He did not have any symptoms of fevers, chills, night sweats, weight loss prior to his hospitalization. He's HIV negative. He began to recover some motion of his legs. He was able to be extubated on April 14th, and he was transferred to us on May 19th. Real quickly, on admission, he was noted that all he could really do was wiggle the fingers of his left hand. That was about it. He was able to breathe on his own, but that was about the only movement he had. As you can see, the infiltrates had gotten better. He still had that granuloma right here. Okay. We started him on a number of cases, a number of drugs, including 4 drugs, but you also added cycloserine and moxifloxacin. If we have time later, we could talk about it. We continued his Crohn's disease, his medications for ulcerative colitis. I guess we can quickly ask this, and then I want to go on, but we can talk about this later. But do you agree with the TB regimen? Yes. I wouldn't have started cycloserine. I wouldn't have started moxifloxacin. I wouldn't have started either one of them. And then I think the most important, which I see you guys already answering, I like it, that I never agree with what David starts. So thank you for your support, as always. All right, guys. You know, I don't like that last one is really coming up. Wait, you don't have to change. Look at them. I'm pressuring. This is the cool thing about these voting. I'm actually pressuring them into changing their votes here, you know. Just real quick, and we could talk. I mean, the guy had involvement. He had osteomyelitis, and moxifloxacin is a very, very good it has good penetration into bone. He also had involvement of the spinal cord, and again, cycloserine he had. But I do want to emphasize, and I think you guys are right, that there is no evidence whatsoever that I can use to back up my decisions here. It's just something we do here, but I don't think anybody would argue with you just starting with 4 drugs. And look, after I started talking, I never agree with Dave. Only went up to all the way up. I mean, I don't like that. But the bottom line is that he became a smear culture negative since May 20th. We found him that he was, because of all the Decadron they put him on, he had what looks like probably iatrogenically induced Addison's disease. We had to treat that. His serum levels were low, and again, for the sake of this case, it's not that important, but that is something very common that we see in diabetics. And I think in one of our future grand rounds, I think the whole role of TB and diabetics and drug levels is important. But this is another one of those cases I think all of us are seeing where diabetics don't respond the same way. And we increased his dosage. He did much better. And the bottom line is, interestingly enough, on admission, his quantiferin was positive. So his IGRA tests were positive. With intensive PT, he's now actually walking. It's a miracle. I mean, he is now walking with a walker, with a wheelchair. And interestingly enough, he will not allow us to do any more MRIs. He is afraid of MRIs. He won't let us near the MRI. But things seem to be getting better. But what's happening is he does have now on the CT, it looks like he's starting to lose some height in his vertebrae from the previous infection. Also, he has severe narrowing of his disc space now, as you can see. So what's happening now is that he's being evaluated for spinal reconstruction surgery down at the University of Miami to try to help that. But interestingly enough, and something that we could talk about later again, is since he's been on the TB meds and minimal amounts of medications for his ulcerative colitis, we did not continue the tumor and necrosis factor blockers. He's had no flares whatsoever of his ulcerative colitis. So we could maybe talk. But what I'd like to do is, you know, I think this case really to us here at AG Holly and to all of us really brought home a very important point that tumor necrosis factor blockers are really, really important tools that we have for some of horrible inflammatory diseases. But they're very potent, and that's what makes them good. But they're very potent, and that's also what makes them dangerous. And I thought what we wanted to do today, if it's okay with you, is to kind of talk about inflammation in TB. And what I'd like to do is go back to something that I think most of you there that are listening are starting to shiver. We're going to talk about basic immunology. And for most of our clinicians, you know, we shiver when we hear this. But the reality comes down to is TB is mainly an inflammatory disease. And so is so many other diseases, especially a lot of our diseases that we call autoimmune, or we're not so quite sure what causes them. Inflammation plays a very important role, and I think we need to know about it. And I'm so honored today to tell you that we have I think, a distinguished friend who's going to be joining us, Ivan Fuss. Yes, that's right. Me and Ivan actually went to medical school together. We went to a carpool. Ivan used to have to listen to me for 3 to 3.5 hours a day. Ivan went to a mental home for a little while, and he's back now, but he's doing much for no. But Ivan is a staff clinician in mucosal immunity at a section at the NIH. His research interests include analysis of cytokine pathways, abnormalities, and their relationship to the occurrence of intestinal inflammation in both experimental models and the human counterpart, inflammatory bowel disease. These studies have allowed new approaches to the understanding and treatment of such disease states as Crohn's disease and ulcerative colitis. This has led to innovative therapeutic avenues such as the use of anti-interleukin-12 in the treatment of Crohn's. He's an active member of the Crohn's and Colitis Foundation. He served on the CCFA Grant Review Committee. He's a pediatric gastroenterologist. He serves on their affairs committee. He also is a Research Initiatives Council member, and he's a reviewer for multiple journals. He has won many, many awards, and he was elected to the American Society of Clinical Investigation in 2008. And most importantly, forget all this. This is really, really very impressive. But most importantly, Ivan is a great clinician. Ivan is a great teacher. And most importantly, Ivan's a great friend. So what I'd like to do now, Ivan, are you there?
Yes, I am.
All right, so remember we had an agreement, no bad stories about me. Is that correct?
That's correct.
Ivan is joining us from Bethesda, Maryland. For all you guys, you're not going to be able to see him on video because I don't allow anybody who's better looking to be on video than me. But I'd like to turn it over to you, Ivan. Thank you so much for joining us today. I really appreciate it.
My pleasure. I thank you for the opportunity to talk about inflammatory bowel disease. But I also wanted to say, unfortunately, I couldn't vote on my end, and I have known Dave since college, and I would never agree with what Dave would have picked. So I agree with the rest of you on choice number 5. Starting that off, today we're going to talk about inflammatory bowel disease. And for those of you who are not familiar with IBD, essentially it's made up of 2 disease entities, that of ulcerative colitis and Crohn's disease. And if you could turn to the next slide from the title slide. As you'll see here, IBD in the United States, the prevalence is basically about 100 cases per 100,000. So although fairly prevalent, what we have started to see is that the incidence has started to increase in both of these disease entities, especially over the last 20 years. What we have noticed is that the onset is actually, although listed here as unimodal, it's actually bimodal. What we see is predominantly the peak occurs at about 10 to 19 years of age. However, there is a second peak at about 60 to 70 years of age. It can occur in young children, even that of less than 1 year of age. The main thing from the slide, about a million cases is estimated to be seen here in the United States, and it's about a 50% split between ulcerative colitis and Crohn's disease. Next slide. On this next slide, you're basically going to be seeing what is the prevalence of IBD around the world. And in the red, basically what you see here is the more prevalent the disease is, the redder the area. What you should take away from this slide is what we're seeing is that in the more industrialized nations, or as we've cleaned up the environment and the environment has gotten cleaner, we have seen more incidents of IBD. In third world nations, much less IBD, and in areas, especially in underdeveloped countries like Africa, especially, very little incidence of IBD. Well, you could take two things from this slide. One, that it may be related to genetic factors. However, more relevant, what we're finding out is that the microbiome, or the bacteria that are housed within the intestine, what we've actually done is by cleaning up the environment, we've changed that microbiome. And patients with IBD are especially sensitive to this. So as we've changed it, we've actually allowed their microbiome to change. And in some sense, they've now had an increased reactivity to the microbiome that is now prevalent. And you'll see why in a few slides, why that is relevant. If you could change to the next slide, please. On this slide, basically, we're looking at sort of etiology hypotheses that have been put forth for IBD. Well, predominantly people, as you see in the left upper left-hand slide, persistent infection. People have been looking for, is there a pathogen that is causing IBD? And on the top of this, you see Mycobacterium. Well, why did that become prevalent? Well, if you go back to the early 1900s, people started noticing in cattle, in sheep, in goats, a disease called Jonas's disease. And essentially, if you look at it, it's a granulomatous lesion disease, inflammatory in nature, in the intestine of these cattle. And essentially looks very, very close to that of human IBD. So people started looking at, is there a connection between Mycobacterium and IBD? Both granulomatous type diseases, both inflammatory diseases of the intestine. Unfortunately, although a lot of studies have been done, no real proof has been shown that there is actually a connection between Mycobacterium and IBD. People have tried through RT-PCR as well as culture of the intestine of human patients with IBD, and really no significant long-term positive studies have shown at least a correlation, at least as of yet. People have looked for other types of bacteria, specifically Helicobacter. Those of you who are not involved in clinical care, essentially patients with Helicobacter infection can develop significant gastrointestinal type of inflammation, specifically ulcerations. However, again, when looking for it in IBD, we haven't found it. So unfortunately, although a lot of studies have been going on, we haven't found that one pathogen that seems to correlate with the onset of IBD. However, what we have seen is that there seems to be a defective mucosal integrity, meaning the mucosal barrier and the function of the barrier, meaning if you look at the intestine, it should be a tight junction, not allowing things to go back and forth through the intestine unless it needs to. What we find in the IBD patients is that this does not occur. They actually have very loose junction between the cells of the intestine, allowing bacteria as well as other types of things to go through. So they actually have an impaired, what we call mucosal integrity. Well, why is this important? Well, that gets to our last point in the right-hand corner, the dysregulated immune response. What we find is that if we take the bacteria from a patient, say a normal patient, and mix them with their lymphocytes from their intestine, they don't react to it. They don't start proliferating, and they don't produce what we call cytokines or inflammatory cytokines. What this tells us is that a normal individual is tolerant to the bacteria within the intestine. However, when we take a look at the Crohn's or ulcerative colitis type patients, what we find is that if we take their bacteria from their intestine and mix it with their lymphocytes, some studies have shown that they actually respond to it, and they proliferate and they start producing cytokines. Now, these bacteria that we're finding from their intestine are not pathogenic, but a makeup of normal bacteria that is normally found in it. So essentially what this point from this slide shows is that there's what we call a loss of tolerance, meaning that these patients with IBD are actually reacting to something within their body, in this case the microbiome within the intestine, and therefore auto-reacting to it, and they should not be. Next slide. That brings us to this point, that the chronic inflammation of IBD is not really due to a pathogenic organism, but a dysregulated immune response to antigens or bacteria found within the intestine that normally should be there. So, what is the reason why they're responding? Is there a genetic predisposition to respond to these type of organisms? Is there a problem innately within the cells that make up their immune system? Next slide, please. Well, what is Crohn's disease and where is it found? Well, Crohn's disease is basically an inflammation that can actually occur, although well known for its occurrence within the small intestine, it actually can occur anywhere from the mouth all the way to the rectum. And as we see here, predominantly it's found in the small bowel as well as in the ileocecal area, but it also can be found all the way to the colonic area. The big thing to notice is that the rectum is spared, and this really differentiates it, as we're going to see if you turn to the next slide, that of the distribution of ulcerative colitis. Essentially, you see a colonic disease of origin, does not affect anything but the colon, and is predominantly found in what we call the right-sided area, or rectum and sigmoid and spreading upward. So a continuous type of disease whereby we have rectal involvement. Next slide. For those of you who have not seen ulcerative colitis, this is an endoscopic view of UC. And essentially what you take away from this, it's an ulcerating lesion. It is very bloody. It is very continuous disease, what we call a pancolitis or a lead pipe type of appearance, meaning if you looked at it, the normal architecture of the intestine is gone, and it almost looks like a dilated lead pipe with a very ulcerating, bleeding area that is continuous in nature. That is in opposition, if you turn to the next slide, to that of Crohn's disease. And what you're looking at here on the left and the right is basically what you see is that there, yes, indeed, again, inflammation, not as bloody or bleeding in nature, and they have what we call aphthous ulcerations, those white streaking areas, basically are ulcerations that are occurring within the mucosa. And if you turn to the next slide, a high-power view of that ulcerating or aphthous ulcers area. Now, why is that important? Well, if we, in the next few slides, when we get to the microscopic view, These aphthous ulcerations are actually made up of lymphocytes and antigen-presenting cells, basically macrophages or monocytes, or a differentiated type of monocyte called dendritic cells that are found in the intestine. And basically a lot of these cells confluence to form what we call a granuloma, very similar to what you see in tuberculosis. Next slide. If you look at the histology of ulcerative colitis and Crohn's disease, markedly different types of diseases. You see predominantly a superficial ulcerating lesion caused by, as we're going to see, a different type of T cell, whereas Crohn's disease, we're going to see a transmural lesion, meaning all three layers of the intestine are involved, with a lot of lymphoid aggregates, meaning a lot of lymphocytes aggregate around each other with the formation of granulomas. There is crypt abscesses. In both, you're going to see goblet cells diminished or normal in nature, but one of the distinguishing features in Crohn's disease, as we see on the lower right, granuloma formation, very, very frequent. Next slide. We can actually skip this slide and go to the next one, please. You should now be on a slide where it says Crohn's disease and ulcerative colitis. And essentially what we're seeing here is a microscopic view of both Crohn's and UC. And that brings out the point that I spoke about last slide, that Crohn's disease, a transmural disease affecting all three layers from the mucosa all the way down to the submucosa and serosal layers, we find inflammation. And as we see on the left, the early formation of a granuloma within the intestine, essentially an aggregate of these lymphocytes with antigen-presenting cells like macrophages surrounding it. As opposed in UC, we find a very superficial disease, very ulcerating in nature, but affecting the top layer, does not go down to the deep layers, does not form granulomas. And the reason why is, as we're going to get to the immunology, hopefully you'll get a better understanding of why we can form granulomas in Crohn's, but not UC. Next slide, please. Now we're on a slide which should say T-cell differentiation. For those not familiar with immunology, immunology is not actually that scary. It is very basic. The main thing you need to take away from it is that cells can talk to each other and activate each other. And once they're activated, what do they do? Well, if we look in the middle of this slide, we're going to see a cell called Th0. And basically, that's a naive type of T cell, a undifferentiated T cell. Well, this naive T cell can go along various pathways. It needs a certain activation or kick to it to tell it to where it should go or where it should differentiate. Well, if it's in the presence of a master cytokine called interleukin-12, as we see on the top-hand part of this dichotomy, if that naive cell sees IL-12, it could differentiate to a cell called Th1 type cell or a interferon gamma producing type cell. So essentially, it could diverge, form this Th1 if IL-12 is there. Well, if IL-12 is not there, or it goes to what we call a default pathway, or if it has a kick or activation or in the presence of a different type of cytokine, as we see on the bottom, like interleukin-4, it could differentiate to a immune Th2 type cell. Why is that important? Well, that cell can produce a large amount of IL-4, IL-5, interleukin-13. Why is that important? Well, if we look at the function of these two different types of cells, Th1 cells producing predominantly interferon gamma can cause the killing of bacteria or antigens or foreign particles if it's presented in the body. So basically it plays a very big role in host defense. If something comes in that shouldn't be there in the body responds by making these interferon gamma Th1 type cells to see that antigen, differentiate, attack it, kill it. However, the body has another way of responding. Essentially, it can produce, in the presence of interleukin-4, these Th2 type cells, producing a lot of what we call Th2 cytokines like IL-4, 5, and 13, and they have a prominent role on B-cell differentiation, or they talk to B cells. So again, you have this crosstalk between cells. And essentially, why is that important? Well, your B cells are very important in differentiating when they see an activational factor into producing immunoglobulins. And the immunoglobulins, again, another way of your body responding to a foreign type of attack and trying to clear it. Next slide, please. Well, I talked about initially innate and adaptive immunity, and you're kind of figuring out what in the heck is he talking about. Well, it's very simple. Again, immunology can be broken down into very simple talk. Cells talk to each other. What is innate type of immune system? Well, that's your macrophages, your monocytes, your dendritic cells, your differentiated type of antigen-presenting cells, meaning when foreign particles come into your body, they're taken up by these antigen-presenting cells, as shown on the left. The DC, what it stands for, is dendritic cell, or a differentiated type of macrophage or antigen-presenting cell. It takes up that antigen. It gets activated. That dendritic cell can produce that master cytokine interleukin-12. And that can tell the naive T cell to become and differentiate a interferon gamma-producing cell and go and attack that foreign particle and kill it. Well, interferon gamma, as we see on the lower right, can have another function. It can actually go back and talk to these antigen-presenting cells, or macrophages, or MAC for short, and they could become activated, and they could produce factors like TNF-alpha. TNF-alpha and interferon gamma have very similar roles. They're types of cytokines that are produced by various cells that can attack cells and kill it, and keep what we call host defense, meaning if there is a foreign particle coming in, it can go attack it and clear this particle so that the invading antigen is cleared. Next slide, please. Well, TNF-alpha, as you saw from the previous slide, like interferon gamma, can have some host defense mechanisms. It can, in and of itself, go and attack an organism or a foreign type of antigen or evading type of pathogen and clear it. It can also have an effect of what I call the zip code effect, meaning you're in one zip code, but you really would like to be in another zip code. You're sort of envious of that other area. Well, TNF-alpha can help you. What it can do is actually start, when it hits a cell, it could start making it produce certain factors that allow cells to migrate from one area of the body or one zip code of the body to another zip code. And why is this important? Well, to help clear infection, you need a lot of different ways to clear that pathogen. Interferon gamma is great. It can start killing that pathogen in and of itself, but sometimes you need a little bit of help. And what happens is TNF-alpha can actually recruit cells to start coming in, to start clearing that infection. Next slide. Well, how do we put this together? Well, if you look at this slide, it's actually a lot less complicated than it is. what this represents is actually when you get immunized, what happens? Well, if you think of immunizations when we were a kid or more recently, if you've gotten one, what is it? You're actually putting a foreign particle or a foreign antigen into the body. Well, when you put that antigen into the body, as we see on the top-hand part of this slide, antigen-presenting cells that I've talked about, like macrophages or monocytes or in the intestine dendritic cells, take it up. And what happens is it talks to another cell. That antigen-presenting cell talks to a T cell, as we see that TH cell. And what does that TH cell do? Well, it becomes activated. As I said, when cells talk to each other, they become activated. And that T cell starts proliferating. It starts making more copies of itself. And it starts differentiating. And as I said, if you differentiate a cell, you can differentiate it along different pathways. Well, you can differentiate it to make cytokines, as we see in the middle part of the cell, so that it can actually start clearing that antigen so that your body doesn't get overwhelmed by it. However, it can also talk to a B cell. And basically that B cell starts differentiating, and once it starts differentiating, it turns into a very mature type of B cell called plasma cell. And that cell starts producing immunoglobulin. And the immunoglobulin can also help fight in host defense. So a lot of the factors that I talked to you about, basically in a normal immunization, can occur and help us in host defense. Well, turn to the next slide. What happens in IBD? What goes wrong in this immune cascade? It seems very finely tuned, but yet these patients, something goes wrong, and they develop inflammatory bowel disease, specifically Crohn's disease. Well, turn to the next slide. This should now read key inflammatory mediators in Crohn's disease. Well, if you look at this slide, it's actually the same slide that I talked to you about host defense. Basically, cells like antigen-presenting cells or macrophages and dendritic cells talking to T cells to differentiate them to make interferon gamma, and that interferon gamma talking to macrophages or MACs and making things like TNF-alpha. Well, what we find in Crohn's disease is that there is an innate problem with both their antigen-presenting cells, like dendritic cells and macrophages, as well as their T cells. What starts happening is when they're presented with a foreign antigen, their dendritic cells, macrophages, or monocytes hyperproduce or increased amounts of IL-12 are found from their dendritic cells. And these increased amounts of IL-12 then work on T cells to become differentiated, and what we find is that they have a hyperproduction of interferon gamma, which then works on their MACs or macrophages to start making TNF-alpha and hyperproduce TNF-alpha. So what has happened is a normal response, which should occur, is a hyper-response. So basically, they're hyper-responding in their immune system along the host defense pathway. Next slide. And as I call it, I like to call this a double hit. You don't need to really worry yourself about the terminology, but if we look at the dendritic cell on the left-hand side, what we find is that as we've screened patients for genetic disorders, we're finding that there's a fair amount of patients that can have a disorder within their antigen-presenting cells, genetically, systematically prone to it, to overproduce the master cytokines like IL-12, which can work on these T cells, which actually hyper-respond to the IL-12 to become interferon gamma-producing cells. Next slide. And essentially, what we have found in this slide where it says Crohn's disease results from a dysregulated immune response, what we find is that what they may be hyper-responding to is actually the microbiome within their own intestine. This is one factor. It is not the only factor that they're probably responding to. But what we have found, and as you may or may not know, as clinicians, many patients, and in this case particular that Dave gave, when we place patients on antibiotics and change the bowel flora, patients with IBD can get better. So if you change that microbiome within the intestine, the patients seem to get better. So we're taking out at least one of the initiating factors, or trying to cut that inflammatory cascade that has been set in motion. Next slide. Now, what is the immunologic factors in IBD, specifically ulcerative colitis? Is IBD the same disease? Meaning, is Crohn's disease UC, and why don't we see granulomas in UC? Next slide. Well, this slide, again, a little complicated and a little busy, but follow and walk me through. There's been a lot of animal models that have been put forth of ulcerative colitis. One of them from Dr. Wendy Garrett and Laurie Glimcher at Harvard, called the truck model. Again, the basic immunology really don't need to be concerned about, but what we have found in this animal, basically where we have sort of messed up their T-cell receptor, and that's what the TR stands for, or a T-cell receptor T-bet ulcerative colitis model. What we see is that, as shown in Figure A, this animal can develop ulcerative colitis type lesions. Well, we see if we mess up the T cells and dysregulate them, we can get inflammation resembling that of ulcerative colitis. If we look in the part of the slide just beneath that histology, what we find in these animals is a very large amount of TNF-alpha being produced. So we see that TNF-alpha can be important, at least in this animal model. Next slide. But more importantly, what we find in this animal model is that if we treat them, as we see in Part A, with antibiotic therapy, we can actually knock down the disease. So if we change the innate bowel flora within this animal, we can actually start treating this animal model. And indeed, the TNF-alpha levels start to decrease. But more importantly, what Dr. Garrett showed is, if we look at the bottom half of the slide, what they show is they looked at the microbiome of this animal, and they found that there was particular organisms that were produced that seemed to be very prevalent in the animal with inflammation as opposed to an animal without inflammation. But what it showed is that these types of organisms were innately found in both the animal without and with the inflammation, but more so in the animal with inflammation. So again, the takeaway from the slide is that the animal seemed, as in humans, possibly responding to the innate microbiome, and that it's set in motion because of factors maybe genetic in origin, still to be proven, but we know that if we mess up the ability of their cells, like the antigen-presenting cells or the T cells, to respond, they could hyper-respond to an innate factor within the intestine. Next slide. Well, if we turn to another animal model, one that I and a colleague, Monica Boravant, looked at some years ago, if we take a chemical called Oxazolone, and we usually use this in skin sensitivity type reactions, if we give it, instead of painting the skin and looking for a reaction, if we give it intrarectally to a mouse, if we look on the right, lo and behold, we find inflammation very similar to ulcerative colitis, meaning ulcerating lesions, as shown in the middle part of the slide and bottom part, and a very superficial edematous type of mucosa, as shown on the top. But most importantly, if we turn to the next slide, what we find is that this type of animal model is driven not by normal T cells, as I've talked about, like Th1 and Th2 type cells, which can differentiate according to what cytokine it sees from that naive Th0 cell. We find that it is actually involved by what we call natural killer, or NK T cells. And why is this important? Well, NK T cells are a very old type of way of dealing with pathogens. It is a initial responder. It is a cell that can produce both interferon gamma and IL-13. And in the case of the NK T cell in ulcerative colitis, what we find is that there's a special type of glycolipid or antigen that activates these NK T cells. Well, again, why is that glycolipid important? Well, if you go back to your microbiology, glycolipid is actually the cell wall of bacteria. When the bacteria gets killed and the cell wall is released, you get glycolipid formation. Well, these glycolipids can activate NK T cells. So again, what we're seeing from that truck model from the slides before and the slides here is that we find an innate response to the microbiome that seems heightened. So it is not pathogenic type of organisms, but maybe the innate type of cells or antigens within the intestine, that cells within the body, which maybe again have the ability to respond, in the case of ulcerative colitis, NK T cells hyper-respond and go and attack the epithelial cells, causing ulcerations. Next slide. I won't get into this. Next slide. And next slide. Let me know if you don't see it. It should say IL-13 enhances cytotoxicity. The reason this is important is these NK T cells, as I've said, what they can do is in the presence of this IL-13 that is produced by the NK T cells, it forms a cascade that feeds upon itself. And by feeding upon and activating the NK T cell, this cell becomes activated, and what we're seeing here is if you put these cells in culture with epithelial cells, as shown on the right-hand part of each of these slides, as you add in IL-13, the ability of the cell, or NK T cell, to attack the epithelium and destroy it becomes heightened. So again, what we're seeing is in ulcerative colitis, again, a autoimmunity type disease, meaning the body is self-responding to something in a heightened way with its own innate cells for host defense and attacking the cells within the body. In this case, NK T cells through IL-13 and TNF-alpha, causing tissue destruction. In the case of Crohn's disease, interferon gamma and TNF-alpha, causing tissue destruction. Next slide. And that brings us to the last part of the immunology, at least part. We see that Crohn's disease, and you see very different type of histology, very different types of immunology responses, as I've said. But what happens? Well, when you form a interferon gamma and TNF-alpha response, you basically try and form an attack response against that pathogen. And what happens is you draw in cells to start coming around and confluence around that foreign particle and trying to clear it, i.e., you form a granuloma. Whereas in ulcerative colitis, you predominantly have an NK T cell producing 13, causing inflammation and causing the release of TNF-alpha from other cells like macrophages, and therefore causing tissue destruction and ulcerating lesions, but not granuloma formation, and an inability to form granuloma formation due to this particular type of immunologic response. Next slide. Next slide. Let me know if you're not. You should be on a slide called Biological Treatment Now and Strategies. Well, with a little understanding of the immunology, how do we treat IBD? Next slide. Well, initial treatment started looking at, well, we know in at least Crohn's disease, there seems to be a very large Th1 response, or at least one part of the inflammatory response in Crohn's disease seems to be this IL-12 interferon gamma TNF-alpha driven type response. Well, if we try to inhibit that response by giving patients monoclonal antibodies directed against those types of cytokines, can we make a dent in this disease process? Next slide. Well, that gets us to the generations of TNF-alpha antibodies and really to the heart of the talk today. As we see on the left, we initially started out with a mouse antibody. A lot of the studies were done in animal models, as I've shown you. And what we saw in these animal models is if we used a monoclonal antibody directed against TNF-alpha, we can actually inhibit the disease or at least ameliorate in a large portion of Crohn's and UC patients their disease process. We then got to what we call a chimeric antibody, and that, in a sense, is infliximab or Remicade. Chimeric antibody, what it stands for, is that part of it is mouse and part of it is human, and it forms a chimerism or a joint fusion between the mouse and the human antibody. And then finally, we got to the fully humanized antibody on the right, adalimumab, which contains no mouse protein and essentially is fully human. Next slide. If we look at these anti-TNF biological agents up close, we see infliximab, which basically has the mouse portion and then the human portion as shown in the yellow. Adalimumab, fully humanized antibody, contains no mouse portion. And then we have a third type of anti-TNF-alpha monoclonal antibody that you may have heard of called certolizumab. Certolizumab, very different type of antibody, as I've tried to show you on this structure. Instead of the usual, what we call a FAB portion, or what we call the praying hand area, or the top area, or the FC portion, which binds other cells found on the bottom of each of the infliximab and adalimumab areas, certolizumab only contains the FAB portion, the top area. It contains no FC or binding capacity to other cell portion. And that's going to be very important later on, as I'm going to show you. Next slide. Well, this is just to show you infliximab had a very big influence on IBD, as big of a risk as we've seen from the case today. Why do we treat patients with infliximab with Crohn's and or ulcerative colitis? Well, in this case study, this was one of the initial study results from treating patients with Crohn's disease with infliximab. If we gave them 3 doses at 2, 4, and 6 weeks, we could see a response rate up to 64% and a remission rate in about a third of the patients. And these were really the worst of the worst type of non-responsive type of Crohn's patients. So again, a very big response in patients who hadn't really responded to other medical therapies, at least at that time in the 1990s. Next slide. And indeed, if we looked at the ability to keep patients in remission, as shown in this slide, and take them off steroids, what we find is that both adalimumab that we see here, as well as infliximab and certolizumab, as compared to placebo, had very similar types of results, about a 60-something to almost 65% response rate, and at least about a third to about 40% of the patients going into remission. So many of these drugs, despite their similar nature, meaning adalimumab and infliximab looking very similar in structure as compared to certolizumab, which has a markedly different type of structure, still had very similar rates of activity and amelioration of disease process. Next slide. If we get then to, does this work in UC? Well, we know it works in Crohn's. Did it work in ulcerative colitis also, despite being different immunological factors occurring? Well, if we look at the trials, next slide, please. We should be on a slide called Act 1 and Act 2. This is the test results from treating patients who had really been refractory UC type of patients with the different anti-TNF alpha type inhibitors. And what we find is, indeed, although the response wasn't as great and the remission not as great as Crohn's, you still had a marked response and a marked inhibition in ulcerative colitis patients, telling us that in both Crohn's and in UC, these anti-TNF alphas inhibitors can have a marked amelioratory type response. Next slide. Well, just getting back to UC, why should it work in UC? In Crohn's, we sort of knew, well, you get that Th-naive type of cell that when it sees an activational factor becomes an interferon gamma-producing cell, and then it starts activating macrophages to producing TNF alpha, and downstream you get a very marked response by inhibiting or getting rid of that TNF alpha response. Well, why does it work in UC also? Well, as we see on this slide, again, going back to that immunology type of response, again, we don't have to be that concerned with the nuts and bolts of it. But as I said, that glycolipid, at least we think, activates that NKT cell to produce IL-13, which can start a cascade and activate the NKT cell to start killing that epithelial layer and causing tissue destruction. Well, TNF-alpha, in combination with IL-13, actually upregulates the receptors on these NKT cells to become responsive to activation. So if we take away that TNF-alpha, one, we take away a very deleterious type of cytokine causing tissue destruction. We also take away an ability of those NKT cells to become activated because we no longer have the ability to upregulate those receptors. So what we're trying to do, as I said in the first part, cells talk to each other. Let's try to find a way to disconnect that crosstalk. And that's what sometimes this anti-TNF alpha seems to be doing. Well, next slide. If we look at the anti-TH1 biologics, meaning if we look at infliximab, adalimumab, we saw in the previous slides that they seem to have a very similar effect on at least Crohn's disease patients. Well, there is another type of TNF inhibitor called etanercept. Many of you have used it, used very widely in rheumatoid arthritis type patients. Well, etanercept is basically a molecule that has the ability to bind to TNF alpha and sop it up, if you want to say, in the peripheral blood, and therefore takes away TNF alpha from the body. So yes, it can have anti-inflammatory type effects by taking away that deleterious type of cytokine causing tissue destruction. But yet, as we see in this slide, etanercept only had about a 10% ability of putting patients in remission, whereas infliximab and adalimumab had anywhere from 35 to 40% ability to put patients in remission. So clearly, etanercept, although it had the ability to clear TNF-alpha, did not have the same amount of ability of treating Crohn's patients. Why? Next slide, please. That gets us to how do these anti-TNF-alpha type of monoclonals work? Well, as I said before, cells talk to each other. They give signals to each other. Well, these monoclonal antibodies also can talk as well as give signals, as well as ability to interact with other types of cell types. Initially, the thought was that infliximab causes what we have termed apoptosis, or normal cell death of cells. Cells have a natural lifespan, and they naturally undergo cell death at a programmed time. Well, the question is, in IBD, time with a of monoclonal antibody, the full-shape type of structure. And what it's doing through its bottom area, or that FC portion, is it's actually going and attacking cells and adhering to it and giving it a signal. Well, what are those signals and why are they important? Next slide. If you look at Crohn's patients and their laminar propria, what this shows is when we look on the left-hand side, controls just normal patients, cells that we taken from the intestine of normal patients. And then we activate them in a Petri dish. And essentially, when we activate them, a lot of the cells, as we see from this curve, going upward, undergo cell death. The y-axis is apoptosis, or programmed cell death, or ability for cells to undergo death when given a stimulus. So a normal person, when they get an antigen exposure, they become activated, they do their job, and then they die. Well, in Crohn's patients, what happens? If we look in the middle portion of this slide, when we activate their cells in a Petri dish, they don't do anything. They don't undergo cell death. They just stay there. That's telling us they have a defective ability to undergo cell death, or ability to undergo a program type of normal response when seeing an antigen. So if they see an antigen, they see it, and they keep responding to it because they don't die. Next slide. Well, in the initial studies some time ago, when they looked at infliximab-treated patients with Crohn's disease, and they looked at the intestine, and they took slides from the intestine and made histology and looked for apoptosis, meaning cells undergoing cell death. As we see in the bottom half of this slide, those little red dots, those are basically T cells that are undergoing or have undergone cell death. So as you treat a patient with infliximab, they seem to regain the ability to undergo cell death or die. Next slide. Well, the T cells not only looked like they had the ability to undergo cell death when they saw infliximab, but also their antigen-presenting cells, like monocytes and macrophages, as I've told you, that produce that IL-12 master cytokine that direct the T cells to make interferon gamma, as well as the MACs, or macrophages, that produce that TNF-alpha. What we see on this slide in the gray shaded bar, as these patients got TNF-alpha inhibitors, and we looked at their macrophages, monocytes, dendritic cells that produce these cytokines, they started to undergo cell death and had the ability to undergo cell death. So we saw we not only affected the innate immune response, like the APCs, the MACs and the monocytes and the dendritic cells, but the adaptive immune response, meaning the T cells that produce the gamma and the TNF-alpha. Next slide. Now, you're looking at this and going, oh my God. Well, this is pathways that are involved in cell death. But again, it is a very simple type of theory if you think about it. cells talk to each other. And as I like to call it, this type of slide, it's called red light, green light, go. Meaning you have various pathways and molecules within cells that talk to each other. And they give a signal from one to the other to finally give a signal or a green light for the cell to undergo apoptosis, as we see on the lower left-hand side. But there are stop areas, meaning that red area, caspase 3, a master type of molecule that can, if it doesn't get the correct signal, it won't die. It won't give that final signal. It'll give a stop signal or a red light and won't allow the cell to die. Well, as we see, there are various molecules, as we see in the top right, that start off this process within the cell. One called BCL2, which basically is a long-lived factor. The more you have it around, the longer, if you think about it, the L portion of that term, the cells live longer, or L for living longer. Well, you can have stop portions, again, not only at the end of the cell, but at the beginning of the cell. If you get a signal not for the cell to die, you could stop it right then and there. Well, what happens in the Crohn's patients? Next slide. Studies by my good friend Monica Boravant, what she showed is that the Crohn's patients not only had a inability to undergo programmed cell death or a natural way of dying in the cell, if we looked at in the Crohn's patients on the right, or CD, when we activated the cell, they actually turned on that long-lived protein called BCL2. So we're seeing innately the cells in these patients with IBD are screwed up. They don't get the correct signals. They get the signals actually to hang around and to be around and to hyper-respond to these antigens. And is it because they don't die? And the best way of treating the patient is a way of giving them a signal for these cells to undergo cell death so that they could then clear these type of cells that are hyper-responding. Next slide. Well, if you look at this slide, again, what is the take-home message? What does infliximab do? Well, if we look on the right-hand side of this slide, where it says CD3 and CD28 stimulated type cells, again, we take cells from the intestine of a patient who have been treated with infliximab. And what we find is that if we look at the top-hand portion of the right part of the slide, the y-axis is called BAX, BCL2. What we're looking at is the stop signal. That BAX is a stop type of signal to that long-lived molecule. So again, what it's doing is giving us that red light. It's telling us, stop that BCL2 from being produced, and now allowing the cell to undergo cell death. So we're changing the internal structure, or changing the signals of these pathways to figure out the cell can finally say to itself, I need to die. I need to undergo cell death.
Do you hear what we're hearing?
Next slide. And what we find is that when we treat the patients with infliximab, you finally, as we see on the right-hand side, if you just put infliximab cultured with cells from the intestine of patients with Crohn's disease, they get that final signal, caspase 3, and it allows it to get a green light, and it goes and it dies. So beforehand, they didn't have the signal. Now you're opening up the floodgate for the cell to finally recognize that it undergoes cell death. Next slide. Well, etanercept, we saw before, didn't have as much potency as the infliximab or adalimumab in the treatment of Crohn's. Why? Well, what we saw, if we look at this slide, is etanercept, although it has the ability to bind to TNF and sop it up, so it can have some anti-inflammatory properties, it doesn't have the ability to bind to a cell, to give it a signal, to undergo apoptosis and undergo cell death. And what we see here, the y-axis again, cell program death or apoptosis. And as we see in the open types of squares, that is cells treated with etanercept. They undergo, to any large degree, cell death, whereas in the dark black circles, we see infliximab-treated patients can undergo cell death. So one of the big differences between the anti-TNFs, at least so far, can they induce apoptosis or cell death? Next slide. And essentially, if you look at the machinery, remember I told you the red light, green light, go type molecules. When they talk to each other, you finally get to that final molecule, caspase-3, which can give that light for the cell to undergo cell death. What we find, if we look at infliximab-treated patients in the black bar, they get that signal as we saw before, and as we see here, increased amounts of caspase-3 are now made. But etanercept, as shown in the striped types of bars right next to it, don't get the same signal. They don't get that final kick to talk and tell the cell to undergo cell death. Next slide. Well, what happens in tuberculosis? There was a paper a little while ago that Dr. Ashkin had alerted me to by Dr. Wallace. And essentially what Dr. Wallace did is if he took normal peripheral blood cells and infected them with mycobacterium, or basically co-cultured cells with active mycobacterium, and then added in vitro adalimumab, infliximab, or etanercept, what happened? Well, he saw a marked difference. If we look at the y-axis, it's interferon gamma production from these cells. Now, as I said, when a cell or a Th0 cell sees an antigen, it could differentiate and starts making gamma. Well, in mycobacterium, it's not infection. It's not dissimilar to what we saw in Crohn's. What we're seeing is that mycobacteria comes in, it activates cells to start producing interferon gamma to start trying to quell that infection. And it starts bringing in other cells through TNF-alpha to migrate or change its zip code to come, and what happens is all these cells coalesce around the organism to try to kill it and try to clear that infection. Or you form, in the case of the mycobacterium, the granuloma, the makeup of large amounts of lymphocyte or T cells producing gamma and TNF-alpha, and these antigen-presenting cells producing TNF-alpha. Well, when you give the adalimumab and infliximab, you actually see, as shown on this slide, on the bottom half of the slide in the open circle and open squares, that the interferon gamma production from the lymphocytes goes down. So somehow you're clearing, by giving anti-TNF-alpha, you're clearing either T cells making gamma or you're clearing their ability to make gamma. But as we see in the top hand diamond, black diamond, etanercept has little response and has little ability to clear the interferon gamma. Very similar to, as I showed you, in the responses of cell death in the Crohn's patients. Next slide. Well, Dr. Wallace looked at apoptosis, and early on, statistically, due to the Y error bars, he did not see any differences, at least in apoptosis, between the different types of TNF inhibitors. But he did see, as time went on, and that there was a possible difference between infliximab and adalimumab versus etanercept. The way he put it is he did not see direct apoptosis of the cells or cells undergoing cell death, but he couldn't exclude that the TNF inhibitors were binding to the membrane portion of a cell and causing it to undergo cell death. And as we see, as time goes on and you get more and more stimulation, maybe the cells do indeed undergo apoptosis or cell death. And that gets me to the next slide. Bringing you back to that slide, we've seen so far that that fork-shaped type of monoclonal, adalimumab or infliximab, can bind to cells, kill them, or give them signals to actually undergo cell death. But on the right-hand side, we also see that infliximab can bind on to TNF-alpha which can be found on various types of cells and also give it a signal to undergo cell death. And this also may be a possibility which may be occurring in tuberculosis, that actually cells are being coated and show TNF-alpha on the surface. The anti-TNFs go and they either give it a signal to kill or they bind on to the TNF on the surface and they give a reverse signal to it to undergo cell death and tell it to undergo cell death. Next slide. Well, if we use these TNF inhibitors, do we need to be concerned? As we've seen from this case study, this patient actually had a significant mycobacterium infection. Well, listed here are the possible side effects of using anti-TNF-alpha. The most common is initially when you give anti-TNF reagents, they can have an infusion site reaction or develop a serum sickness type of illness after the infusion of the monoclonal antibody. However, what we have also seen, and the most significant that we, as gastroenterologists myself, are concerned with, is infections, whether mild or serious, demyelinating disorders like optic neuritis or a myelitis, which again, the neurological complications that we saw initially when you gave the anti-TNF, would you think that was due to TB? Because they can indeed have a reactivation of latent TB or serious infections, or was it a demyelinating type disorder that we were initially seeing from the anti-TNF therapy and wouldn't have even thought of TB? Well, what I need to instill into you, you need to think of all of these types of reaction, infection, neurologic complication, and long-term, as we see on the bottom right half of the slide, malignancy. Next slide. Well, are serious infections more common in patients taking anti-TNF inhibitors? At least what we've seen in Crohn's and IBD UC type patients, if they're on a single med like for their ulcerative colitis or Crohn's, like steroids, the odds ratio of having a serious infection is 2.9. However, if we start adding in other immunomodulators like 6-mercaptopurine or these antibiologics like anti-TNF-alpha inhibitors, we start seeing that odds ratio of having a significant serious infection go up dramatically. Next slide. Well, what is the risk of dying from sepsis? This is in IBD patients. These I pulled were the most largest studies done. We see that the risk of death from sepsis or just general sepsis from any organism, about 4 per 1,000 patient years. So it is prevalent. You need to think about it. Is it as common as we thought? We need to think about it. We need to know it's there. Do we need to be afraid of it? Yes, but with the right type of screening, we can actually, hopefully, not be involved with these serious infections. Well, what are these opportunistic infections these patients can develop? As we see here again, there are a variety of different types of infections, and as we see in the middle, atypical mycobacterium can occur. But again, what we're looking at is per 1,000 patient years. So again, putting this perspective, how much probability of this is, if we look at the probability, as one of my good friends, Dr. Corey Siegel would say, these odds ratio or risk ratio, it's about the same risk of dying in a car crash. So it is there. You need to think about it. Is it going to happen every day? No. Well, next slide. Well, what type of patients are dying from anti-TNF inhibitors? They're usually older type of patients. They usually have comorbidities. And again, as I showed you before, they're usually on multiple different types of immunosuppressive drugs. The young, healthy type of patient that you start the anti-TNFs to begin with may not be as at risk as these type of patients. Next slide. Well, we've seen the acute problems, the long-term problems of anti-TNF inhibitors, that of lymphoma, or specifically non-Hodgkin's lymphoma, again, can happen about 6.1 per 10,000 patient years. So again, can happen. We need to think about it. But again, if we look at the next slide, one of the other types of malignancies that can occur, hepatosplenic T-cell lymphoma, these types of lymphomas can occur, but if we look at it in all the patients that have been infused with infliximab, we have seen that there are now 16 cases in all the patients that have been infused, and we're talking hundreds of thousands, almost millions of patients that have been infused with this type of antibiologic. So again, what we have to note, as shown on the next slide, hepatocellular T-cell lymphoma, again, can occur. As we see in the light blue, we see about 16 cases now total. What we see is that most of these types of patients had been on other types of immunomodulators. What we have seen is that patients who have gotten co-treated with 6-MP and anti-TNF are at risk for this hepatocellular T-cell lymphoma, but more importantly, Warren, I'll be there in about 15 minutes. What we see is that patients that had not been treated with that have been treated with anti-TNF alone do not seem to have the ability to develop this hepatocellular T-cell lymphoma. So again, it seems to be the co-immunosuppression. We don't know fully the immunologic responses that are putting these patients at risk, but the take-home from this slide is that these types of things need to be thought about as we need to think about serious infections, but in the long term, how prevalent are they? Next. Wrapping up, and why think about what happens when a patient comes to you. Well, we see a lot of primary immunodeficiency type patients here at the NIH. When they come to us, they have a variety of immune disorders. Well, how does this relate to IBD, and how does this relate to mycobacterial type infections? Well, we see a large portion of our patients that can develop, as we see on the right, with mycobacterial infections. Predominantly, what we start seeing in these patients is that they have T-cell type defects. And what this chart basically shows is that what types of cells are affected and what types of infections can you get. Well, with mycobacterium infections, predominantly the T-cell and the monocyte seem to be screwed up. And as we've seen from the immunology from IBD and the normal host homeostasis, interferon gamma plays an important role, and specifically T-cells from that make interferon gamma producing cell play a predominant role in curbing a antigen or a pathogen response like mycobacterium, and monocytes, which produce TNF-alpha, also have a distinct role in trying to curb that infection. Well, next slide. Well, what types of patients, when we see the mycobacterium in patients with mycobacterium, what types of immune defects do they have? Well, as we see in the middle portion of the slide, it looks like a lot of mumbo-jumbo, but what we take home from it, predominantly, they have IFN, which stands for interferon gamma. They have interferon gamma receptor abnormalities. They have IL-12 receptor abnormalities. So basically, they have a screw-up in the IL-12 interferon gamma pathway. So when you screw up that pathway, you screw up the ability to respond and kill the mycobacterium. Well, how does this play a role? Next slide. Well, putting this in perspective again, cells talk to each other. As we see on the left-hand portion of the slide where it says microorganism, if we think about it, when mycobacterium comes into the cell, it comes into an antigen-presenting cell, like macrophages or monocytes, they take it up. They become activated. They give a signal. They release cytokines. Well, in a normal response, this cell becomes activated, and as we see on the bottom half of this slide, they produce cytokines like IL-12, one of the master cytokines, as well as other types of cytokines which help, as we see on the right-hand side, the T cell to differentiate it, make interferon gamma, as we see on the top-hand portion of this slide, come back, interact with its receptors, those little diamonds on the left-hand side where it says underneath macrophages. The interferon gamma is bound to its receptor, activates the macrophage, sees that antigen, and it gives the signal finally to kill it. Well, next slide. What happens if you have those immune defects? If you have a screw-up in interferon gamma or a screw-up in IL-12 or inability for that macrophage or antigen-presenting cell to activate the T cell to make gamma? Well, what those lightning bolts show is that each of these areas, we see an immunodeficiency type of patient we've taken care of, which developed mycobacterium, which had an abnormality either in the ability for IL-12 or interferon gamma, or as we see on the left-hand side of the slide, TNF-alpha acts very similarly to gamma. When macrophages are activated, they make gamma, they can make TNF-alpha. When you use an inhibitor or you knock it out or you're immunodeficient and have the inability to make these pathways to make gamma or TNF, you leave the body open to have persistent mycobacterium infection. Well, next slide. In a patient that we saw from South America who had gotten a BCG type of vaccination, as I said in the initial parts of our slide, when they were vaccinated, you make a normal host response and a memory response to deal with that antigen. Well, in these patients with primary immunodeficiency, as you see here, they actually develop mycobacterium infection. And this patient actually had an IL-12 receptor defect, so the inability for that IL-12 to function normally to activate T cells to make gamma. And we see on the next slide, initially they started making caseating granulomas all around, and when we treated them actually with interferon gamma, as we see on the right, we got rid of the granulomas. So, immune system is a double-edged sword. Activated too much, we get autoimmune disease like Crohn's disease and ulcerative colitis. Try to inhibit it with anti-TNF inhibitors, we down-modulate, or as a good friend and colleague, Dr. Steph Targan calls it, we reset that rheostat. We reset that thermostat down to normal. So we go from a heightened response down to a normal response. But if we take a patient who has a normal response and now they're immunodeficient by knocking out those immune regulating pathways, they're now open to the inability to respond to microorganisms, in particular one like this, mycobacterium. Next slide, and we're almost done. Well, is this important? Should we not treat, as we saw the patient here, he developed mycobacterium infection? Should we not treat patients with IBD because we're afraid of these infections? Well, as you see here, as we've treated patients in the biological era, pre-treatment, horrendous disease. After a few treatments, we see a normal bowel. So again, this type of treatment has had a marked response on the treatment and therapy of IBD patients as well as other patients with autoimmune disease. We can't be afraid of it, but we have to know what we're doing and use it cautiously. Last slide, please. And this is just to let you know what we've talked about today is in that red box. We've seen how cells can become activated and respond through dendritic cells or DCs or antigen-presenting cells to make your T cells respond and fight off pathogens. If they hyper-respond, we start making autoimmune disease states like Crohn's disease. If we knock it out by knocking out TNF-alpha with TNF-alpha specific inhibitors, we could down-modulate that inflammatory response. But that's not the only way of treating patients. And as I've shown here, in the age of immunology, it's becoming more exciting because, as I said, cells talk to each other. As we've understood how the cells talk to each other, we're now trying to work out ways to knock out their inability to become activated, as shown on the left, to transport itself, as shown in the middle, and to respond in other inflammatory cascades, as shown on the right. Thank you.
Ivan, that was absolutely fantastic. I don't want to say nothing, Ivan, but from somebody from Brooklyn like you to make somebody from Brooklyn like me understand this was quite remarkable. I mean, Ivan is fantastic, and, I don't want to say nothing, but also from Brooklyn, how the hell do you say all these terms like
Exactly. It took me a while to practice it, okay?
Yeah, don't you think it should just be called Joey the, Joey the, and there should be a lot of Vinny the, right? I mean, I don't know how we can name these things.
Exactly.
But I really want to thank you tremendously, and hopefully, if you can, stay on if we have questions at the end. But
sure.
I think one of the most important things that Ivan has put forward, is that obviously these are very, very powerful tools, and these are tools that really can change these diseases. But in the process of doing it, just like Ivan said, I agree with him, we can't be afraid to use them. But what we need to do is we need to at least be able to know what may be a potential and how we can maybe screen for it and prevent it before it happens. And that's why I have the tremendous honor of introducing Sundari Mase. And as you guys know, Sundari is the medical officer from the CDC. Sundari works with us at the RTMCCs, and she's our medical consultant and really has tremendously helped all of us. And Sundari's going to talk now from a clinical aspect on tumor necrosis factor blockers and TB and how to further what Ivan said. What do we need to do to try to screen these and potentially treat them? So, Sundari, thank you so much for joining us today.
All right. Thank you so much for having me here, Dave and Southeastern National TB Center. And also thanks to Dr. Fuss for an amazing presentation and setting sort of the background for the clinical talk. Of course, Dave is a very hard act to follow, and I'll do my best. And I agree that the hardest part of this talk is pronouncing these drugs' names, because I can't. So what I'd like to do, let's see if I can figure out how to advance these. Right click? Oops. Oh, okay, got it. Okay.
Right click and then push next, okay?
Okay.
There you go.
All right. Okay, so over the course of the next 15 minutes or so, what I'd like to do is to discuss the association between an epi of TNF inhibitors and tuberculosis specifically. I know we've already discussed some of this already. Discuss the challenges of diagnosing latent TB infection in these patients that have underlying immunodeficiencies prior to starting TNF inhibitors. I'd like to discuss the use of tuberculin skin test versus IGRES in diagnosing these patients with LTBI, and then talk some about risk factor assessment for tuberculosis and how that plays a role as well in the treatment of these patients. I'll discuss some potential recommendations for LTBI screening of this population prior to placement on TNF inhibitors, and then hopefully we'll have time for a short case presentation. There we go. All right, so this is just a great chest X-ray classic for reactivation TB. So first I want to just talk about our more common immunosuppressive agents, prednisone, glucocorticoids, and the association between those and tuberculosis. The risk of reactivation TB is poorly defined even in this setting and is based on anecdotal reports from the 50s and 70s. But the CDC 2000 TB statement does state that patients who are on greater than or equal to 15 milligrams a day of prednisone for 1 month or more are at increased risk of progression to active TB and should be carefully screened and followed. And this is the dose that's been shown to suppress tuberculin skin test reactivity as well. There's no real observational prospective data to support this, but retrospective studies in low incidence areas have been unable to demonstrate any risk of TB. So this is a challenge. So more on prednisone and TB from Jick et al. The data is from the General Practice Research Database in the UK, and TB cases were looked at between 1990 to 2001 with controls, and current glucocorticoid use showed there was an odds ratio of 4.9 in those patients for progression to active TB. And if you looked at the subset of patients receiving less than or equal to 50 milligrams a day, the odds ratio dropped to 2.8, and in those receiving the higher dose, the 15 milligrams a day or more, the odds ratio was higher at 7.7, supporting the hypothesis that indeed these drugs do predispose towards progression to active tuberculosis. Of course, we don't know whether they're causal versus the severity of the underlying disease. These cases and controls were matched on common other risk factors, body mass index, lung disease, diabetes, other TB risk factors. But of course, patients receiving glucocorticoids were sicker because they're on the medications for an underlying reason.
I'm sorry.
So now let's look at biologic drugs. TB is only one condition or one illness that's associated with these drugs. But as you can see, there are many other infectious and non-infectious conditions that are associated with the use of these drugs, and I think Dr. Fuss mentioned many of those.
Okay.
So I know we've heard a lot about TNF, and I probably don't need to go into this particular slide, and in fact, I'll skip it since we've heard a lot about it. But I do want to say that the overexpression of TNF-alpha does lead, as you saw in the last presentation, to inflammation and tissue destruction and immune-mediated inflammatory diseases, rheumatoid arthritis, IBD, psoriasis, ankylosing spondylitis, other such illnesses. And we've already seen from the last presentation what the rewards of TNF-alpha blockade are and the highly successful treatment with these drugs. So again, I'm not going to go into great detail since Dr. Fuss really covered this area well. There's many such agents, and there's monoclonal antibodies as well as etanercept, which we've heard about the difference in mechanism of action. So actually, I want to reflect some on what happened with infliximab. So when it was noted that this drug predisposed towards progression to active TB in October of 2001, the FDA modified the labeling to include a warning about infliximab-associated active TB that included instructions to screen for latent TB infections prior to starting the medication, and also had a statement about potential continued screening afterwards at some interval, but the interval was not specified. So after that FDA warning came out, between November 2001 and May of 2006, there were 130 reports received by the FDA of patients developing active TB on infliximab. And of these 130 patients, 19 of them died. So it's a real problem. Oh, and so looking at this particular slide here, this is a study looking at the UK Biologic Registry, and basically showed that in patients receiving infliximab, monoclonal antibodies, that is, there's a 3 to 4 times risk of developing active TB over those receiving etanercept. Again, showing that the monoclonal antibodies appear to be more of a risk factor for progression to active TB disease than etanercept. And the general case rate in the UK at this time was 12 to 14 per 100,000. You can see that in those patients receiving anti-TNF agents, the case rate was 95 per 100,000, and cases of TB that occurred over this time period was 27. And this is basically showing the exact same data in a graphic form, again showing that of these 3 agents, etanercept had the less likelihood of having patients progress to active TB than the monoclonal antibodies. Here's a U.S. population-based study, Kaiser Permanente, Northern California. The background rate of TB in this population of Kaiser patients was 2.8 per 100,000, and the background rate of non-tuberculous mycobacterial infection was 4.1 per 100,000. But then you can see in those patients receiving TNF inhibitors, the rate was much higher, and you can see again the same the same thing with etanercept being less of a risk for progression to active TB than infliximab and adalimumab. I think I said that correctly. So we've actually heard a lot already on this topic of, why potentially there's more TB risk with monoclonal antibodies. My friend and colleague, Kevin Winthrop, who's probably one of the leading experts in this area, believes then, of course, that the interferon gamma downregulation and differential granuloma penetration, much of which we heard in the last talk, plays a role in why these monoclonal antibodies might have carried more of a risk for progression to active TB. But here are some of the mechanisms that have been proposed. And I know that Dr. Fuss actually went into this in great detail, so I'm going to go ahead, in the interest of time, skip this so we can get to the clinical piece. And I'll skip this slide as well. Okay. All right. So I want to really underline and highlight the importance of screening patients for risk factors for tuberculosis when deciding whom to test, whom to treat. Obviously, any patient that's going to go on these drugs needs to be tested for latent TB infection, and if the testing suggests that they have latent TB infection, active TB disease must be ruled out with a chest X-ray, symptom review, prior to placing the patient on treatment for latent TB infection with one drug. The risk factors here are very important to be aware of and to ask patients about. Known or prior exposure, obviously, to an active TB case, birth or extended residence in a country where TB is prevalent and endemic, a history of living or working in congregate settings, like we saw in the presentation by Dave, jail or prison, homeless shelters, healthcare centers that treat TB patients, anything that puts the patient at higher risk. And then a history suggestive of prior LTBI diagnosis, prior positive TB skin test or IGRA, chest X-ray findings suggestive of sort of old or scarred TB. Of course, in that setting, you need to get sputa to rule out active TB prior to placing the patient on LTBI treatment. But this is very important and plays into the process of evaluating these patients. Okay, so let's talk some about interferon gamma release assays. And just a quick background, interferon gamma is a component of the cell-mediated immune response, antigen-specific secretion, stable and measurable. That's kind of the background for how these tests are applicable. We know that there are different tests, interferon gamma release assays for TB. There's QuantiFERON TB, and it's Intube right now that's used, that measures a change in the interferon gamma concentration, measuring the interferon gamma by ELISA technique. And there's T-spot or LE-spot, where the actual change in the number of cells releasing interferon gamma is measured by counting spots. And I could go into more detail into this, but in the interest of time, when we move on, if there's questions, we can take them afterwards. So, let's compare the IGRAs and TSTs quickly. Of course, the IGRA is performed outside of the human body, and the TST is performed in vivo or in the human body. IGRA use TB-specific antigens, whereas the tuberculin skin test, it's basically this mulched-up TB, and so there's multiple organisms. It's purified protein derivative. You don't have to worry about boosting when using IGRAs, whereas boosting can be of relevance when using the tuberculin skin test. IGRAs require one patient visit for a result and 2 patient visits for tuberculin skin test. And the results, unless batched, are within 24 hours of IGRAs, whereas, as you know, with tuberculin skin test, patients return 2 to 3 days later. And there's inter-reader variability of the tuberculin skin test, whereas potentially more consistent readings with IGRAs. So how is this different in this set of patients? Well, the specificity should not be different at all. The fact that when patients have had prior BCG or prior exposure to non-tuberculous mycobacteria, that they might have a false positive TST is something that applies to all patients. And we think that because the IGRAs are targeting TB-specific antigens, that you have much greater specificity. So So if the patient had BCG, they would hopefully not be positive with an IGRA, even though they could have a false positive tuberculous skin test. How about the relative sensitivity with TST for LTBI? A study performed by Matulis et al. 2007 looked at patients who largely received BCG and had inflammatory rheumatic conditions, were treated with anti-TNF agents, and 12% of the patients were quantiferon positive versus 40% that were TST positive. And the quantiferon in-tube test more closely was associated with LTBI risk factors, suggesting that in these patients, many of them had false positive TSTs as a result of having BCG. Again, we see this in other populations as well, but it does support the use of IGRAs in this situation. Here's a study from Peru. Again, very high BCG use in both the cases and the controls. Cases were patients with rheumatoid arthritis, and controls were patients without rheumatoid arthritis. And as you can see here, it appears like the prevalence in this setting was about 68% TST positivity. That's what was expected in this community setting. And in the controls, you see about 66% of them were positive by TST. But in those with rheumatoid arthritis and immunodeficient condition, only 27% had a positive TST. The controls, quantiferon correlated well with TST, being 59% of patients had a positive quantiferon, and did not correlate that well with TST in the patients with rheumatoid arthritis. So the thinking here, the bottom line is perhaps quantiferon is picking up patients who really have latent TB infection better than tuberculous skin test. There are numerous other studies that show these findings, and I'm not going to be able to go through all of them. But the take-home messages: you can have anergy with tuberculous skin test and with IGRAs in patients that have immunodeficient conditions. Those are patients that we've been talking about. Indeterminate results do occur, and they're difficult to interpret. And it's very important, though, that we have the best sensitivity in this situation, because we are actually trying to find patients with latent TB infection and treat them before putting them on these drugs. So the test that has the greater sensitivity is the most important. Okay, this is just a slide that's quickly showing what's happening in different parts of the world. You can see that different countries are doing different things. Britain is using risk assessment and has no initial screening test. They don't use IGRAs or tuberculous skin tests, but use chest radiographs and actually empirically treat with INH for those from high prevalence countries, which is a very interesting approach. Other countries, Switzerland, France, and Germany, use IGRAs to screen these patients in addition to risk assessment and chest radiographs. In Spain, they're using two-step TST. All these settings were, of course, risk factor assessment is very important. And as you can see, the American College of Rheumatology, CDC, and in Canada, recommend the use of tuberculous skin tests in this setting. So let me just quickly go through this, and then we should move on to the case. So what do you do when you have a patient that you're thinking of starting on a TNF-alpha blocker inhibitor? Careful history for the TB risk factors that we discussed. TST and or interferon gamma release assay. If there are no TB risk factors and the tests are all negative, then you presume the patient is uninfected with tuberculosis, latently infected. If the TST is positive and the IGRA is negative, then you might want to take into account BCG history. And if the patient has a history of BCG, presume they're uninfected. With no history of BCG, diagnose TB infection. If the IGRA is positive, diagnose TB infection. Now, let's just say we have TB risk factors, the risk factors that we discussed. Exposure is likely. Then still, if the patient is negative on both of these tests, TST and interferon gamma release assays, presume they're uninfected. If either is positive, diagnose TB infection. So that's just sort of an algorithm. It's not in any guideline. It's not a CDC recommendation by any means. However, it is an approach to the patient that might be quite useful. So how about TNF inhibitors in TB disease? Anecdotally, in a few case series that I was able to find, it stated that these patients are more likely to have extrapulmonary disease, like our other immunosuppressed patients, HIV patients, that sort of thing. Diagnosis is more difficult as a result of it being extrapulmonary, and the presentation could be quite severe, like we saw in Dave's case. Patients may be more likely to have immune reconstitution inflammatory syndrome. Drug-resistant TB might be harder to diagnose because it's hard to get a bacteriologic diagnosis, and discontinuation of the TNF inhibitor may worsen the underlying condition. So let me move on. I think the next thing I have is a case. And I want to note that, I have seen many patients actually who have progressed to active TB who have been on the TNF-blockers over the last 10 years or so. And the presentation is difficult. The diagnosis is difficult because it's not the typical presentation. So this is a patient that I recently saw in my clinic, 70-year-old white female, long history of rheumatoid arthritis, treated with Enbrel or etanercept injections every week since 2003. Her rheumatologist did screen her per the FDA recommendation with a TST, and it was negative prior to starting treatment. She had no risk factors at all for TB except for a few cruises she'd taken. And she presented with a left neck swelling in the supraclavicular area, fevers, chills, night sweats, a 10-pound weight loss, slight cough, interestingly enough, and general malaise. She looked awful when I saw her. She was referred by her rheumatologist to a surgeon because he thought that she was at risk for lymphoma. TB was not in his differential at that point. The etanercept was stopped. There was surgical full excision of the node, and as we know, in these settings, surgeons rarely send these specimens for any kind of microbiologic testing. So the patient just, the tissue was placed in formalin. Lymphoma was excluded, but the path revealed caseating granulomas and inflammation. She remained TST negative, but her quantiferin was indeterminate. Chest X-ray was normal. Exam was normal except for the biopsy site and, of course, the general symptoms she was having. And her sputum was collected anyhow. Even with a normal chest X-ray, it's very important to exclude pulmonary disease. And what would people do at this point? Would you refer her for a bronch for further diagnostic purposes, treat empirically as MAC, treat with standard 4 drugs empirically for TB, send the specimen for PCR and treat empirically for MAC, or send specimen for PCR and treat with standard 4 drugs for TB? Okay, it's interesting. I think most of you decided to do what I did, which is basically to send the specimen for PCR and treat with standard 4 drugs for TB. And it would not have been incorrect to add treatment potentially for MAC as well. So the specimen was sent for PCR. Patient started on standard 4 drugs. Her rheumatoid arthritis, however, was disabling at this point. She was not able to get out of bed, barely, wanted to be put back on the etanercept. So what would you do? When to restart the TNF inhibitor? Would you wait until her TB treatment is complete, start the etanercept once the patient has completed the initiation phase of treatment for TB, start it right away, or switch to another TNF inhibitor? Interesting. Okay. Well, keep in mind, she's clinically deteriorated to a point where she can't get out of bed. So waiting until TB treatment complete, although we might want to do that, wasn't an option. So what I did was I called Kevin Winthrop, who I told you was the expert in this area, and said, Kevin, what would you do? And he said basically, since she's not smear and culture positive pulmonary, you can restart it right. Just restart it right now, because she's so debilitated. So I went ahead and restarted it right away, and she did quite well. So let's see here. Hold on. So PCR negative, and I've had very bad luck with PCR for TB on specimens that are in formalin. I've had a very low yield. I know Dave's had a better yield. The etanercept was restarted, and then she felt terrible with arthralgias and myalgias that were debilitating. She was on a standard 4 drug regimen at this time, and I didn't expect any microbiologic diagnosis. So what would you do at this point? Check LFTs, check her uric acid, stop all the TB meds, or stop the pyrazinamide? Again, I don't think any of these are wrong. If you stopped all meds, then you would just restart sequentially. But in this case, since it wasn't hepatotoxicity, and I really thought the PZA was what was the problem, I went with stopping the PZA. And, again, I don't think any of these things is wrong necessarily to do. Hang on a second. Okay, there we PZA was stopped. She was immediately much improved. Really interesting how PZA affected her so significantly. Treated with 3 drugs for 2 months and then just INH rifampin for the next 6 months, and she has 1 month to go. So in other words, she's going to have 9 months of standard regimen. She's much improved, has gained 10 pounds, back to swimming and normal activities of daily living. So I guess I'll end there. Yes, I want to acknowledge all these folks, especially my good friend Kevin Winthrop for helping so much with the presentation, and thank you very much.
Sundri, thank you very, very much. You can't go anywhere, though, Sundri. You know, what I'd like to do now for a second, I know we're running late. We're going to go probably another 5 minutes or so to just entertain some questions. And if you have any questions, 2 things you could do. Operator, would you mind explaining how to unmute and ask a question by phone?
Sure, thank you. Ladies and gentlemen, if you would like to register a question, please press the 1 followed by the 4 on your telephone. You will hear a 3-tone prompt to acknowledge your request. Your line will then be accessed from the conference to obtain your information. If your question has been answered and you'd like to withdraw your registration, please press the 1 followed by the 3. If you are using a speakerphone, please lift your handset before entering your request. 1 moment, please, for the first question.
Operator, is there a question there?
There is no question at this time.
Okay, fine. And then on the other way, if you would like to just ask a question via the chat, if you push on the top where it says Q&A and follow the directions on the screen right now, click Q&A, type the question, click Ask, and then we'll be happy to answer it too. Sundri, fantastic, and thank you very much. You know, when you hear these presentations, these case presentations, to me there's 2 things in common. One is, interestingly enough, I think the good news is the word's gotten out. I think people, for the most part, are thinking TB and trying to screen for it. The bad news is the same thing we face in TB is having a good test to screen for TB. And what I think makes it worse, actually, is that we do TB all day long. We feel comfortable with the inconsistencies of the skin test or inconsistencies of the IGRS that we're learning more. What I think is making it more and more difficult right now is that a lot of people doing the screening are not familiar with TB. They're not familiar with skin tests, you know, rheumatologists, gastroenterologists. And I wonder what your opinion is. I think we may need to, how do we get the word out more, and what do you think are some of the issues, how we can improve it?
Yeah, I think that's a great point, because these patients aren't coming to us in public health and in TB control. They're being seen in the community. And so training and education for these groups of gastroenterologists, rheumatologists in the community is a key thing. But you know, one could also argue that possibly these patients should be referred to public health for evaluation, or at least there should be consultation with public health and TB control when the patients are seen in their private office setting.
Because I think one of the biggest problems is, you know, I think what we really need is a definitive yes-no. The skin test, I think, for all of us leaves a lot of to desires. You know, like, is that really, is that induration, or is it not, or is it erythema, or vice versa? I mean, one of the hardest things, like at least for my case, as a TB person, he had risk factors, he had an x-ray, I probably would have started him no matter what any of these tests, but that's something of years of experience, you know. What about the IGRS? I think one advantage may even be that the IGRS, even though they may not be more sensitive, or maybe one of the nice things they either for the most part are or not, or even if they're indeterminate, it says think TB still. What do you think about that?
Yeah, no, I agree with you 100%. And I don't, you know, having reviewed the literature, I still don't have a really good sense of which test is necessarily better. I mean, when some places would use a skin test first, if it's positive, you're done, essentially. You would think, potentially, if there's risk factors. I don't know. What do you think about that, the use of IGRS versus TST in this setting?
You know, I would almost say that in a high-risk patient or a patient I'm really concerned, I may even try both.
Yeah.
You know, and I agree with you. I'd also like to get it to somebody who has experience. And I think one of the big problems we're having right now, to be honest with you, and I'm seeing it all the time, is, you know, we're having a rheumatologist, somebody, and nothing against them, but they don't do skin tests every day. Our health departments do hundreds of skin tests a month, you know.
Yeah.
But they flop it on, and then the answer is yes or no. I agree with Ivan. I think these are, even though we don't have to really lose sleep, worry about, but it is concerning. I think we do need to screen adequately, and I think we need a better algorithm. And I do agree with you. I think if there's a question, there's a risk factor, you're not so sure, I think they need to get help.
Yeah, and I also think that in the setting of where you're going to put someone on a drug that significantly increases the risk of progression to active disease, should we really be thinking false positive? I mean, if you have a positive TST, although there are risks associated with treating LTBI, it would be a hard call to not treat, I think.
I agree. And here's, we're getting some questions, so if I could read some, Sonia. So it goes along where some of the questions, we're seeing more patients who are having both a skin test and an IGRA for TB. What's your thought about this approach?
Right. I think, as Dave just said, great approach, I think, if you're able to do that, because the additive value of both tests is there.
Well, and I think, again, we always got to look at, in this situation, just like in HIV, we're looking for a high sensitivity. We're looking for an excuse to treat.
Exactly.
And I would add, not only just, I think you'd agree, skin test and IGRA, but in this kind of case, I do think there is a role for an X-ray and risk factors, and I think we need a simpler way to list those risk factors quick, and this is what you do, because, again, we need a really high sensitivity. We really almost want to opt towards treating, if you agree.
I totally agree.
So how long, again, they kind of asked this question, and you kind of touched on it. I think it was a great point. So how long would you how long would you wait to restart the tumor necrosis factor? And
well, this is the one where I had to, call Kevin Winthrop, and he really felt in the setting of somebody who has a higher bacteriologic burden, waiting at least until culture conversion to ensure that the person is going in the right direction and ruling out drug-resistant disease prior to starting the TNF inhibitor is very important.
And if I may, from the lecture we heard today from Ivan, remember something very important. The immune system, for the most part, it doesn't look like really, for most cases, can kill TB. All it's trying to do is contain it. Right. And that's what the inflammatory response is all about. That's what the granuloma is all about. And what's happening by using a tumor necrosis factor blocker or steroids, we're stopping our body from being able to contain the infection. The infection grows. But the antibiotics, on the other hand, they truly do kill TB. So I think as long as we can get adequate amounts in there, I guess all of us would feel better if we gave it at least 2 weeks, because 2 weeks you really decline the number of organisms tremendously. But if you have no other alternative, again, all we're doing is stopping inflammation. We're not necessarily causing it to grow more, as long as the person's taking the meds and they're adequate meds.
Yes.
And that's why, just real quickly, another thing in these kind of cases, I think there is a role for rapid molecular testing.
Yeah.
Because one thing you do need to do, you need to make sure you're getting this person on adequate therapy fast.
Right.
And that's where, in my opinion, in a case like this, we need to know if the person's eye nature or sensitive. Because if they're not, you may need to add more drugs.
Right. Definitely before restarting a TNF inhibitor.
And, and again, I think there's a lot of questions, which we totally agree is, the CDC implies to use one or the other, either IGRA or TST. Using both as a complement to each other seems a better approach. Are there any guidelines? And again,
there are no guidelines, and I think it's something that actually should happen. I think that our guidelines are based on evidence-based data, and there isn't a lot of evidence-based data, but it's a great thought that CDC should look at this, like they've looked at guidelines for the use of IGRA, that sort of thing, and come up with some recommendations.
And, and for the last question, because we're running out of time, but I will want to say something, please. If you do have questions, if you email them to us or use the chat function, we will answer them, or at least to the best we can. But I think it's a great question to end this, because I want to put you on the spot. I want you to sweat. You come to Florida from Atlanta, it's 30 degrees up there. I want to show you how hot. I always hear about hot Atlanta. I'm going to show you hot Florida. Here's a question for you, and I'm running out of the room. Sheila Allen in Tennessee says, there's a great interest in using the new 3-HP regimen for treating LTBI. And given the study limitations of Study 26 in terms of representation of immunocompromised patients, do you think it's appropriate to use 3-HP right now in immunosuppressed individuals like prednisone or tumor necrosis? And I think Sheila, I like this. Sheila asked it, but it's actually from John. And we got to get back at John. This is a dirty question.
I think so, definitely. And I think you should run out of the room, and I should too. But, this is not a population that was studied in Study 26, and so it would be remiss to make a recommendation to use it in this kind of population until it's studied, and maybe it needs to be studied in an operational setting.
I want to tell you guys, this is a hot topic, and it's something that I think we'll continue to see, and we're learning more and more. But I really do think that the real challenge is not going to be on us. I think the real challenge is that it's happening in the community. And again, this is where I think the TB community, all of us who are listening, because right now we're preaching to the choir, I believe, for the most part. This is where we got to stand up, I think, and really prove, or at least provide the support that's necessary to our community. Because, again, it's all part of TB control. If we do not identify this population, these drugs are great drugs. As you saw in your case, they're saving people's lives. They're making them mobile again. They're decreasing their suffering so much. But, again, like anything, there's risk, and we need to step up to make sure we minimize those risks. And So I'd like to really stop now and thank all of you so much for attending, for being part of this, and doing everything you do in TB control to try to fight this disease, which you do every day. I want to very much thank Ivan Fuss. Ivan did a great job, I think, in really reviewing a very, very difficult topic. And Sundri, thank you for really reviewing the clinical aspects so much. So first, thanks to all of you. Thank you very, very much.
Thank you.
Thank you. Ladies and gentlemen.
At 12:30, we're going to have M&M. Please do me a favor. Please remember to fill out the evaluation so you can get your CMAs and